visual disturbances and what lens we should put that would minimize these. And refractive surprises are, of course, very common. Hyperopic surprises are common, and there is a fixed way to deal with that as well. So the preoperative considerations in IOL power calculation are: number one is calculating the intraocular lens power. The second is which type of intraocular lens should I give to this patient. And the third is managing the patient expectation. So when we come to power calculation in intraocular lens, why is it a challenge in these post-refractive cases in the first place? So there are three major challenges. One is the corneal power that is completely changed. The axial length that is being measured on most of our devices, they are not actually the axial length that we normally get in a non-refractive procedure eye. And the third is the effective lens position of the IOL, or what we call ELP. So we'll go into the details of all of these conversations. So when you look at the scientific papers, more than 30 different methods have been proposed for calculating the IOL in post-refractive eyes, and all of them with very, very variable results. And you can see that all the studies show that eyes that have had refractive procedure in the past have less accurate outcomes of say emmetropia, or closer to zero, than eyes that did not undergo any procedure. So when we go look at the basics, you go back to your cornea chapter and you look at the Gulfstream eye model. Basically, it tells you that the normal ratio is 7.5 to 6.3, and this completely changes when we do a refractive procedure, and we'll talk about how. Um, Patients with LASIK, PRK, or RK, basically, when they have ablated corneas, the central part basically becomes flatter, and in RK patients, both the central and the central part in the anterior and posterior flatten. But in LASIK or PRK, the anterior part of the cornea flattens in comparison to the posterior. And all our topographers basically measure this central 1.6 to 4 millimeter area, and there is a tendency of these machines to basically overestimate the effective refractive power. So what we assume to be the refractive power of 1.337 is not true, and that is where the sources of errors come when we calculate. So the keratometry is measuring only 4 points on the cornea in the paracentral area, ignoring the central regions, and also along with the stromal refractive index that changes. The high central asphericity of the cornea at the center of the cornea is flatter than the periphery after LASIK and PRK, and the Myers that are located further away from the corneal center are actually surgically are now measured, that are the surgically flattened cornea and actually not the central cornea. So these are the points where the keratometry shows the sources of error. So as you can see here, the index of the keratometric index, which is 1.3375, is basically now not the same, because in LASIK and PRK we have removed corneal tissue and the index has totally changed. But all our formulae take into account this index. So the other, not only the K readings which are the problem and the change in the refractive index, but also the other problem is that now we have changed the aberration of the cornea. So by flattening the cornea, we have increased the spherical aberration in myopic LASIK, and also we have done the same in hyperopic LASIK, as well as uh, along with the spherical aberration, we have changed the corneal power. So along with the corneal power and the aberration, now we come to the third point, which is the effective lens position estimation error. So most of the IOL power predictions, basically you measure K1 and K2 and then the axial length, and based on these two readings you get the ELP. But now K1 and K2 is not measured correctly because the proportion of anterior cornea to posterior cornea has changed. So the ELP is also wrong. So how do we measure normally the K readings? So either manual keratometry or automated keratometries, or topographies, which are Placido, slit scanning, Scheim plug, or OCT based. So these are the various ways. So the issue with manual keratometry is that it measures a zone that is 3.5 millimeters away from the center, but it doesn't measure the post-refractive surgery corneas correctly, and it measures the anterior cornea power and converts it into a total power. And in post-laser corneas, which are flatter, in myopia or steep or hyperopia, so it measures the K readings. The IOL master, on the other hand, it measures 6 points in a zone of the cornea 2.3 millimeters diameter, and the lens are again measures an inner of 1.65 and an outer of 2.35. So the solution to this is, instead of relying on the K readings of the keratometers, we should ideally be looking towards the corneal topographers, which give us a little bit of a larger area of the cornea that is measured. And so we get a sim K or an average K value, which would probably be more accurate and more reliable. So this is probably the more reliable tool that we should look at for K readings when we are doing a calculation. So we should look at probably OBSCAN or IOL Master and Pentacams that have larger areas of SIMK measurements, which will give us a more average or a more ideal K reading. So when you look at the intraocular power calculation eyes of previous excimer laser, the ones that have had OCT based calculations or intraoperative aberrometry based calculations, the error of refractive error at the end of the surgery after the procedure is much lower. So coming to the formula, there are 30 power calculation formulae in these patients, but the most reliable ones in my experience are the ASCRS calculator, which is online, that is available, or the APCRS calculator that is available. Basically, you take all the data that you have, and a lot of these calculators also state which machine you are using for the K readings, and you enter all of the um, readings, all the instrument readings that you have, and you basically come to a conclusion. What I prefer is also that I compare 2 or 3 different calculators. So I would, as a rule, always do Barrett Truquet formula for every single patient, along with the ASCRS calculator, which is the Warren Hill calculator. And in my personal optical biometer, I have shamas incorporated into the machine as well. So I look at all 3 and then I make a decision. So Barrett's, in my experience, has been very, very useful and quite efficient in getting us close to that error of 1. Always err on the side of leaving a little bit of myopia, because the tendency of all these patients to have a hyperopic surprise is very high. So Barrett Truquet also incorporates the posterior corneal curvature, which is what makes it a little more accurate. So basically, coming to the point of the formula, if you take a look at this chart, all of these formula have been graded, and there are a few formulae that have an error of less than 1, and most of the errors are less than 0.5, and these are basically the Barrett Truquet, the Haggis, and the OCT RT View incorporated formula, and the Potvin Hill formula. So these are the 4 formulae that we should actually be focusing on when we have a post refractive eye, and we should kind of try and drown out the other noise. Now, the issue with RK corneas, in contrast to PRK corneas or post LASIK corneas, is that the anterior and the posterior both flatten together. So the ratio usually of the anterior to the posterior remains the same, but the flattening is a lot more in the center. So basically, your entire global K readings are extremely unreliable. And more problematic than that is, because it's so irregular, there is a problem of a lot of aberrations, and there is a problem of a lot of visual disturbances. So these are the calculators. Earlier, we would have the historical data also being entered into the Hill formula, which would apparently give more accuracy. But in the recent update, they have removed the historical data. So because that has not actually added to the accuracy. So it is better. Earlier, we used to say, if you have the patient's number from pre-operative, if you have the number pre-LASIK or pre-PRK, and you enter that data, it will give you more accuracy. But after doing all the studies, Warren Hills and the ASCRS formula has removed that from their formula. So this is an example of what the calculator looks like. You can enter all your data in here. Depending on what kind of topo you have, you can enter all the K readings within 2 millimeters, 3 millimeters, 1 millimeter, and you will get your final thing. So of course, most of the new optical biometers also have incorporated formulae in them. The Barrett formula has also been incorporated into the new IOL master. But if you don't have it, you can follow this online calculator with whatever data you have. So just to summarize the IOL power formulae, these formulae, the third generation ones, they work by estimating or calculating the ELP based on the axial length and the K values, and then they incorporate the ELP into calculation of the IOL. But the error comes because the underestimation of the ELP occurs because there is a more anterior IOL position estimated or assumed, and this is what causes the hyperopic post-op error. So, like I said, if you don't have any of these devices, a simple keratometry reading along with your axial length reading, along with lens thickness, which increases the accuracy, and anterior chamber depth, will give you a reasonably close estimation. But if you don't have access to optical biometer and topo, then you need to counsel the patient for a lot higher chance of post refractive. Shamas is a good formula. We used it for years before we had access to topo, but now that we have access to better machinery, it's always better to use the online calculators. So now that we have the IOL power, what IOL should we put in these patients? Should we put spherical or aspherical? Should we put toric in these patients or not put toric? And should we put multifocal or not put multifocal? So basically, if the IOL has if you have eye trace, so if you have access to aberrometry and your aberrations, your high order aberrations are showing higher, then you will avoid putting any of the multifocal lenses. And of course, you will also take a look at your topography to see if the ablation is centered, if there is any posterior corneal steepening, and then decide whether to put toric or to put multifocal. Because if you have decentered ablations, then your multifocal patients will be miserable. And there are very few studies that are there in RK, post RK patients who have put multifocal. They're very small numbers, and we don't have good enough data to use it. So, as a thumb rule, overall, in post LASIK, in myopic LASIK, if because the cornea is made oblate and there is a positive spherical aberration, you can use negative aspheric IOLs such as Technis and Acrisoft and whatever one you want. But if hyperopic LASIK is done because it creates a negative spherical aberration, I don't recommend aspheric. You'd rather just go with a simple spherical IOL. Toric lenses you put only if the astigmatism is more central and more balanced over the cornea. If you see decentered corneas, I would not recommend it. And basically, if you just position your incision right, most times you should be fine. Multifocal IOLs, like I've already said, the cornea is already optically compromised, so most of these patients will not do well with multifocal. But I find that the newer EDOF lenses that are available in the market, such as the Vivity and the iHands, they are doing very well in post LASIK patients and post PRK patients because they don't have too many visual disturbances post surgery. So, just to summarize, the surgical steps in post refractive cataract surgeries, LASIK, we don't see a lot of these cases where there is any interference with the flap margin. But basically, just keep in mind that you should stay away from the margin. The corneal incision should be more limber, and there is a risk of flap stry or dragging of the flap margin. So make sure your corneal incision and your side incisions are more limber. And there are many reported cases of flap edema, even though the flap has not been touched during cataract surgery. Vision stability does take at least up to 4 weeks in a lot of patients. So you have to be patient, and you have to counsel the patient to wait for results, because they are the ones who are most agitated and most restless. Intraoperative considerations in radial keratotomy patients, uh, try and place the corneal incision in between the cuts. There is a risk of the incision opening up, which may need suturing. Corneal edema, especially along the RK cuts, is common, and you can end up hydrating some of them as well. And the stabilization of the cornea and the refractive error in these patients can sometimes even take up to 16 weeks. So be very patient, and keep in mind that these patients still may have a hyperopic jump. This is a video of an RK patient. As you can see, I tried to put the corneal incision in between the two cuts, but the cuts all over there were a lot of cuts. So we tried to basically take a clear area, and The surgery as such has gone off quite uneventful, but as you can see towards the end of the nucleus management near the phacoprobe, you can see this left side area of the incision opening up. You can see the probe on the left side of the probe, the incision is opening up slowly and creating a flap on one side. So after the surgery is complete and hydrating the wounds, basically it's always better to suture these with a 10-0 and just always counsel these patients for the same. The globe otherwise stays quite stable. Also, another thing to note is that you should also keep an eye for endothelial count for these patients, because a lot of them, the high myopes anyway, have a tendency to have a low endothelial count. So the take home message for IOL selection is that make sure you select the right IOL, counsel the patient for visual halos and disturbances. A lot of them will push you to put multifocal or say, I don't want glasses, I don't want glasses. Sometimes these patients do better with monovision rather than putting, any kind of lens with rings in them. For IOL calculation, uh, always try and do a Placido topo to check the ablation pattern, shine plug to calculate the IOL power. IOL Master or Lensar also have good IOL power calculations, and use the online calculators. They are excellent and they work very well. So, basically, to conclude my talk, be aware that in abnormal corneas, less than 65 to 70% in all the studies I showed you earlier come up within one diopter of the target range. So, counsel the patient for a suboptimal outcome, because there is a chance that the patient is going to end up with a refractive error. Err towards myopia, do not err towards hyperopia. Give extra -1, -1.25. If that is what you get, then in the other eye, you can try and adjust them closer to zero and they will have monovision. But if you give them hyperopia, they will be absolutely miserable. Use topographers if you have access to them, they will give you a better result. You'll come closer to zero. Use all the online calculators. And with RK corneas, they do fluctuate through the day, so do check through the day. So that's the end of my topic. Dr. Kavita, any questions? Sir, I always put -1, quite honestly.
Does it depend on the number of cuts?
It depends on, no. Usually, for me personally, I always put -1, because um, the ones that I have seen are 8 and 12. The ones that I have done personally, most of them are 8 and 12 cuts. I have not done any patient with more cuts than that personally. So I always put a target of -1. But I'm assuming that cuts, when you're talking about, you're looking at the K readings as well. So, how do you do
Yeah,
it? Do
that's
you
what.
do it
More
differently?
number of cuts, better to
Go higher.
higher. Yeah,
Yeah.
maybe 16 or 18 cuts. You can go up to -2.
Dr. Kavita, what do you do?
End up with residual astigmatism or new astigmatisms.
Yeah.
Another pointer I also wanted to make, that in LASIK, post LASIK, because we are going to see more and more patients post LASIK, I don't think you can give up the idea of multifocal totally on them. They do well as long as you're getting good readings, you're getting good values on EKR, and these
Central
patients,
ablation.
yes, and it's a central ablation. These patients actually do really well with your trifocal IOLs also. I mean, that's been my experience, so
Yeah.
limited. I don't know if anybody in the audience wants to comment. Yeah. Correct. Yeah. As long as, yes.
So what is your cutoff for abrasions if you 0.5?
Yes, 0.5. So if there, it's a nice, well ablated flap, because we are going to see more and more of these patients who are also the very fact, like she pointed out, they went for surgery because they didn't want glasses, and now they are going to be wanting trifocal. So I don't think you can give up the idea on of that on them. But yes, you just need to be more prudent and do your workup. Not just you do it like a routine cataract surgery, and counseling. I think chair time before surgery is more
As
before, and then
important.
after is always better.
Yes.
Thank you so much, Samita.
Thank
So,
you.
I'm going to be talking on Dr. Sushmita's next talk, cataract surgery in pterygium. She's not here, and the other talk she sent as a recorded video. I don't know if that works. This is mine. No, no, this is yours. Yeah, yeah. No, in this I don't need the audio. In the next one. इसमें नहीं, next one. All right, so I'm covering Sushmita's talk, which is cataract surgery in with pterygium. I think as general ophthalmologists, cornea surgeons, or in just in general, every surgeon who is dealing with pterygiums and cataract surgery, all of us are seeing these patients. So the dilemma always is: are we doing a combined surgery? Are we doing pterygium surgery first? And if we are doing pterygium surgery, how long are we waiting? Now, I think the thumb rule is if you can do your pterygium surgery first, unless it's very small, like say like just a millimeter onto the cornea. If it is on grown onto the cornea significantly, that it's always better to do the pterygium surgery first. Wait for minimum 3 months, let the topography reading stabilize, and then you go ahead with your cataract surgery. But more so if you're planning any premium IOL, like say a toric IOL or a multifocal IOL, if it's a larger pterygium which covers the visual axis, if you're seeing recurrent pterygiums, if you're seeing double-headed pterygiums, if you're seeing any irregular astigmatism, then I think doing, because I see a lot of patients where both the surgeries are just done at the same sitting, and then patient comes back elsewhere, and they're coming back with these residual errors, not very happy patients. If you're doing higher end IOLs, then definitely I would say you need to do your pterygium first and then cataract surgery. Now, when are we going to do a combined case? Like I said, most likely you should avoid doing that, but there would be some patients where it's very small, patient just wants that for cosmetic purpose. If the astigmatism is like say 0.75 and or lesser, or logistically there are some patients, we deal with all strata of patients. If the patient comes from the periphery, doesn't want two surgeries, and that case you may go ahead with a combined case. So I'm just showing this one video where I'm doing the cataract and pterygium combined. So what you're going to do is, first you're going to go ahead with your pterygium surgery, the cataract surgery, and you can do these cases topical. I am doing it topical, actually. There is no block in the eye. Once you've done your, can you switch off the light, please? It's not being seen. Nothing is being seen. I don't think my videos in my first talk was. Apparently, the whole thing is central. He's saying it's shutting in the all over. Are you shutting it? Yeah, I know. Nothing's really visible. Yeah. So should I continue? Yeah, okay. So after you've done with your cataract surgery, then here the pointer I wanted to go give is that when you are trying to excise the pterygium, most of us have a tendency to go like 3 or 4 millimeters away from the limbus. So do not do that. I would say that you need to actually excise right near the limbus, because if you see, the conjunctiva actually retracts and pulls back, and most of the bulk of the pathological conjunctival tissue is near the limbus. And if you feel like in the residual conjunctiva there is some pathological tissue, you can always go back and excise, rather than, if you can see already it's retracted so much. So make sure when your first cut starts at the limbus. And here you can see I'm just holding it with the limbus, with the limbs, and I'm just peeling it off. It actually comes out very nicely like a rexis. You can see you get a nice smooth bed. I have not really used any instrument like a 15 number blade, nothing. I mean, you can always use it later on to make sure you're removing any of those residual tags onto the cornea. You can see you get a nice bed that way, rather than going first with a 15 number. Make sure you're always stripping it. Then that way, once you get that plane, you get a very nice clean surface. Now, following that, here I'm showing this because, if in some, like I thought if there's some student in the audience, I don't typically mark all the time, but I feel this really helps. You go ahead and you measure the area of the pterygium, then you go ahead and you mark it how much you want to excise. As you can see, patient is really moving his eye, and it's being done under topical, but it depends on the pain threshold of the patient. If the patient is feeling uncomfortable at this point, you can use little bit lignocaine and inject it subconjunctively here. It helps to give you that nice bleb and separation, so your dissection here becomes much easier.
So once you've done that, you have to make sure that you are it should be very thin. You don't want any tenon. So what I do is I just once you've got a nice graft, I just keep it on to the cornea and make sure that your assistant at this point is not injecting any saline on the cornea. Here I'm using glue. So you put the glue and then you use your two instruments and just place it, and it like works very beautifully well. If you do not have glue, obviously you're going to use sutures. I know some people use blood and all. I really don't use that because I want a nice cosmetic result at the end. Then you pull your conch here. You can wait for minimum, I would say, wait for if it's a younger patient, especially with a very strong facial, wait for at least 5 to 10 minutes, dry that bed completely, and use your vanas to cut any excessive glue. This iris repositor, I think, works very well to nicely flatten that graft out. So and if you feel at beyond the edges, if you want to just ensure that the conjunctiva is stuck well, you can do that. So I think that's the end of my presentation for pterygium. Sushmita's recorded video, can I just put that on? You'll need to give me an audio input. Yes, please. Yes, yes, Samita. A lot of these patients are very keen, they want a good result. So, and of course this was combined with cataract. Even if you're doing the pterygium first, when the most likely is come to you just for the cosmesis, so make sure that you're and that's the reason I also don't block because in pterygiums, though I know a lot of patients do with surgeons do with block, because then you end up with those hematomas, and which you don't want. So I'm just going to play Sushmita's recorded video. Can you please come here? One of you can come here. Morning, everyone. I'm Dr. Sushmita Shah. Endothelial dysfunction. I think endothelial dysfunction, first of all, it is important to diagnose it, because a lot of times, especially if you're not dealing with corneal problems, then it is very important that you look at the corneal endothelium properly. There are guttate, because as a general ophthalmologist, you're operating these patients and then they come with unresolving edema, like they're going around and taking other opinions. So if you've not diagnosed it, diagnosing it is really harmful for your own image and practice. So make sure you're diagnosing it properly. And because why is it important? First of all, counseling. You can tell the patient that this is going to be a two-step surgery. You may need a corneal transplant, or you will need a corneal transplant. And also the biometry, when you're planning, because if you're going to be doing cataract surgery in a patient who's got Fuchs endothelial dystrophy and you don't budget for the biometry, then the cornea surgeon who is going to do a DSEC in him or a DMEC in him later, or even when you're doing it, he's going to have a huge hyperopic shift. So aim for myopia. Now, while doing surgery, if you want to do both of it together, what is important is that there's going to be a lot of corneal edema, so there is going to be poor visualization. So removing the epithelium always helps. And in these cases, because you're not worried about the endothelium, you're always going to be replacing it anyways, you can use do most of the surgery close to the endothelium and not near the bag, because your visualization will be poor. If you do it near the bag, you can get a PC rent. Always, always, always use a cohesive viscoelastic. If you're doing a combined case, do not use a dispersive viscoelastic. I've seen, in fact, when I was training in the US with Dr. Flugfelder, I've seen his cases where, once the staff gave him methyl cellulose and he just used it, and he had a detached graft the next day. So this is something, which you need to remember, because oftentimes if we are doing more of volume of cataract surgeries, we don't remember. So use only the Helon viscoelastics, because they will be removed completely. Do a smaller X's, because you don't want the IOL popping out of the bag once you're doing the dealing with the cornea. And the Desmet strip will be done after phaco with the OVD in place before putting the pilocarpine. So this is a video which I'm playing. Like I said, it's just like a routine cataract surgery. It's not something different that you're doing, but you just follow all these tips. Use trypan blue. As you can see, most of the phaco is happening in the anterior chamber here, because the visual, I mean, in the video it doesn't show, but when you're actually operating these patients, the visualization is quite poor. So you need to make sure you're not making a rent. And here you can do DSEC, or you can do whatever technique you want. And here I'm just doing the easiest technique which even a general ophthalmologist can follow. You just have a pre-cut tissue and you push the cornea in, and the patient really does well. So thank you, and I apologize for our speaker not being here, and I hope it was a fruitful session. Thank you. So So now hand over, like if the audience has any questions, or we can hand over the hall to the next session. Thank you.